everyone. Welcome to Perfusion Musings, the podcast from Envello Medical, where we're diving into the future of perfusion, oximetry, and cardiovascular care. I'm Casey Boutwell, the CEO of Envello Medical.
And I'm Dan Rodenhaver, the Chief Commercial Officer of Envello Medical. And today we're joined by Dr. Jason Katz. Dr. Katz is a professor at the Department of Medicine at NYU Grossman School of Medicine, Director of Inpatient Cardiology at Bellevue Hospital, and holds a number of other titles and positions. And thanks for being here today to talk about perfusion with us.
No, it's quite a privilege to be here. Thanks for having me.
So one of our first questions, we hear from a lot of people about it's difficult when you see patients come into the ICU or into your facility somewhere. We hear people have all the same problem, which is we know they're sick. Mm-hmm. We just don't know why they're sick. And we'd like to get a little bit more clarity about why it's difficult to determine what might be driving this person's condition or disease.
Yeah, I think that's a great question. We have all these fancy tools and fancy pharmacotherapies and mechanical therapies to support patients who are critically ill, but it ultimately comes down to being able to identify the critically ill patient, or even better, but identifying the critically ill patient before they become critically ill. And that's where we've had a lot of limitations. Us old guys with all the gray hair think we know, right? You can see a patient, they kind of smell like they might get worse. We got a good gestalt that they're going to get worse. Turns out it's probably not much better than flipping a coin, to be honest with you. So, we lack the sophisticated tools for sort of the diagnosis and evaluation of the early trajectory of these patients, which is sort of that critical point in a sick patient's, trajectory and journey. And, it's not just for us, it's for all the people that are touching these patients. Part of the challenge is these patients don't just come to me in my ICU where I'm sort of sitting and waiting for them. They touch people in community hospitals. They touch people in the pre-hospital setting with EMS and EMT providers. Oftentimes they enter our medical system through the emergency department. So before we ever see them, they're touching all these different points. And those are the places where timing of diagnosis and early trajectory assessment could be most vital and most helpful. But again, we just don't have the really sophisticated tools to be able to sort of identify that. And then once we identify that, to know who's going to start getting sicker and how to intervene before sort of this vicious cycle that ultimately can culminate in multi-system organ failure and death ensues.
So when we say we lack the tools, what are we blind to? What is it that you think differentiates one? What are we looking for?
Yeah, I think one is just having the awareness that these type of patients will be presenting to emergency departments or to the pre-hospital setting or to community hospitals. I think just education to the community and even to our own providers at sort of the early entry points to the medical system is really important. And then, we lack a lot of sort of sophisticated tools to understand what's going on with the human body when it's getting ill, right? We have vital signs. We know when patients are tachycardic or they're febrile, where their blood pressure is profoundly low. We know those guys are sick and they're likely to get sicker. It's those that have sort of subtle variations or subtle alterations in their non-invasive vital signs. They're the ones that we just don't have a clue about. And before you know it, you turn around and those patients are then now profoundly ill. They're in shock, they're decompensating, they're destabilizing, they may be arresting. If we could sort of really tease out those that have sort of early subtle changes in their vital signs, early abnormalities in their clinical characteristics, that presentation, that would be helpful for sure.
Is that those subtleties, those patients who were subtle changes, are they the exception or the rule? Or is it sort of across the, sort of an even spread?
I could say they're the rule rather than the exception, right? Again, it's easy when patients come in crashing and burning. Mm-hmm. It's easy when they're profoundly hypotensive. They're in an unstable rhythm disturbance. They're, in shock with multi-system organ failure and decompensating before your eyes. That's the easy one. Doesn't mean it's easy to salvage the situation. Doesn't mean it's easy to treat that. It's still challenging to figure out what might be driving those profound disturbances. But most come in with sort of this sort of subtle decompensation, subtle changes with vital signs, subtle changes in their exam. And their family oftentimes may say, listen, this person is not acting themselves. They're not seeming the same way that they normally do. even before the patient can tell us that. So again, the subtlety, the nuance of critical illness can be, quite dramatic.
I think one of the most elucidating terms for me in learning more about this field is the term decompensation, which implies that there is a compensatory phase and that the body has so many different mechanisms and levers that they can turn and pull in order to maintain vitality until we just sort of run out of reserves and then we sort of fall off the cliff. My interest in that is understanding perfusion in the macrovascular space and this in the microvascular space, and how the difference in perfusion in those two regimes can indicate which patient might become healthy or sick. Can you help us understand more about the physiology of those two different regimes of perfusion and how they work in cardiovascular medicine?
Yeah, I'd like to tell you a lot about this. A lot we don't know still. I mean, again, we sort of rely on this sort of macrovascular, macroscopic presentation of critical illness, particularly in the shock space. We look for overt signs of shock and hypotension, with sort of profound markers of hypoperfusion, with laboratory abnormalities, which can take hours to come back to tell us that that's going on. We look for dramatic changes in vital signs, but we know that's not telling the whole picture, right? When you think about shock, it is by definition a manifestation of hypoperfusion, not hypotension, not tachycardia, not fever, not multi-system organ failure. It is a perturbation in perfusion to the tissues, such that the tissues then become hypoxemic. And then you get all this sort of the macro and microscopic manifestations of that, including little things like endothelial dysfunction and apoptosis and cell death, and broader things like hypotension that ensues oftentimes later, organ failure, multi-system organ failure, and then death.
How would you expect the macrovasculature and the microvasculature to differ between a cardiogenic shock and a septic shock patient?
Yeah, I mean, I think, a lot of what drives vascular tone, the macro and microvascular circulation is multifactorial. A lot hinges on the chronicity of illness, the multiplicity of chronic conditions of organ dysfunction, the ability over time to build up some, as you mentioned, compensatory mechanisms to hypoperfusion, which then can sort of stabilize the patients until, as you mentioned, they sort of reach this ultimate decompensation phase where they're no longer stable. We see that a lot in our shock patients, our cardiogenic shock patients in particular, particularly those that have chronic cardiomyopathies that ultimately lead to shock. They've developed some compensatory mechanisms to ensure vital blood flow to the tissues and to the central key organs. But that's not all of them. Those that come in with, for instance, acute myocardial infarction, they may not have developed compensatory mechanisms for sustaining perfusion and may, as a result, decompensate quite dramatically. Septic patients, they probably don't have the compensatory mechanisms built up over time, because it usually is an acute illness, an acute inciting event, oftentimes spearheaded by acute infection. But again, what we are able to sort of see at this point is this sort of macro circulation, and we assume that that's relatively reflective of the microcirculation, but that's not always the case, right? I mean, you may have a patient with normal blood pressure, and so you're assuming the vascular tone, or at least the macrovascular tone, is reasonable, and that you're deriving oxygenated blood adequately to the tissues and to the end organs. But in reality, you may have reasonable blood pressure, reasonable macrovascular tone, and then the microvascular tone is considerably impaired. And so despite the fact you've got a normal blood pressure, you've sort of stabilized the gross hemodynamics and the vital signs, you may still not have adequate perfusion to the tissues. You may not still be able to adequately extract oxygen at the tissue level, and hence you have progressive, ongoing refractory tissue hypoxemia and all its complications that I mentioned before. Obviously, the manifestations of the mechanisms of injury are different with sepsis and cardiogenic shock. Sepsis we oftentimes think of largely related to a vascular tone phenomenon. Patients develop marked decline in their vascular tonicity, and hence they're not able to extract blood flow, oxygenated blood flow at the tissue level, despite maximally attempting to do that. We don't think of that in the sort of the common forms of cardiogenic shock. That's really sort of, we think of it as a pump problem, but we know from a lot of data that that's not the only phenotype of cardiogenic shock. And in fact, many cardiogenic shock patients will manifest vascular tone, manifest tissue extraction of oxygen in a very similar way to the septic or vasodilatory patient. We know in about 25 to 30% of patients with cardiogenic shock, they're going to have this sort of abnormal vasodilatation, which you don't necessarily see in your sort of classic forms of cardiogenic shock with pure pump failure. So, I talk about all this because phenotyping these patients, phenotyping all the different cardiogenic shock patients, phenotyping the septic shock patients, phenotyping the hemorrhagic patients, we know can be helpful in the management of these patients, at least in identifying potential ways to manage these patients. So understanding the macrocirculation and the microcirculation in parallel, I think is going to be really important to moving the field forward.
And your practice is focused primarily in cardiology and cardiovascular disease. Is this phenomenon true in other patients, other parts of the hospital, other disease states?
I think so. Again, when you think of shock, you think of hypoperfusion. You think about really two things tend to sort of drive systemic perfusion, right? It's issues related to pump function, contractile function of the heart, blood flow, blood availability, tonicity of the blood, and then things related to the vasculature, vascular tone, vascular or endothelial permeability, and those type of things. So in shock, pick your shock type, but in shock, one or two of those things are always impaired. And in many cases, there's a lot of heterogeneity. A lot of it's in both of those factors impairs. There's problems with contractility and loading conditions of the heart, and there's also problems with vascular permeability and vascular tone. Sometimes it's very hard to differentiate the two, for sure, especially when patients first present to the hospital.
We often talk about patients in the use of perfusion monitoring in this conceptual availability of a small perfusion monitor. We talk about detecting shock in patients when they're coming in. Mm-hmm. What role does perfusion monitoring play in the management of recon and helping figure out who can actually be discharged fast, or how can we step these patients in?
I think that's important. Before we talk about that, I think also sort of trajectory, right? It's not enough to sort of understand that the patient is in shock when we come in. Where we really lack a lot of data and understanding is where they are in the trajectory of their illness when they present, right? Some are going to present right at the very beginning. And so a perfusion monitor such as yours could really sort of quickly identify patients early in the disease process. But some patients are sort of in this really rapid downward trend and you just don't know it, right? In order to sort of draw a line in the trajectory of a patient, you need 2 data points. You don't just need one. And some of the limitations in what we have available to us in understanding that trajectory is, we just don't have the sophisticated enough data points. Many of them are laboratory based and can take a while to come to understand that trajectory. We know from the Cardiogenic Shock Working Group, from Critical Care Cardiology Trials Network, from other randomized controlled trials in the cardiogenic shock space, that trajectory, particularly that early trajectory in the first 6 to 12 to 24 hours, matters. It matters to the patients, and it likely matters to us in terms of our ability to intervene before the patients decompensate further and are no longer potentially salvageable. And yes, it's hard to know when you're done, right? It's hard to know when the patients have reached this sort of homeostatic level and are starting to get better. I oftentimes say this about critical care cardiologists like myself. Like, our job is to see a patient who is acutely decompensating, and we take everything out of our tool belt, right? Every pharmacotherapy, every mechanical circulatory support, every intervention, every other machine-based therapy, and we apply it to the patient to achieve some sort of normal homeostasis, to get them back to their normal sort of homeostatic level. And then we're supposed to get out of the way. It turns out it's never helpful to sort of overtreat patients. It's never helpful to stand in the way of the patient trying to make himself or herself better. And understanding when that is, when you've applied enough therapy to the patient, when you should start getting out of the way, when you should start peeling back, that's equally hard, right? And to sort of understand then the trajectory of recovery. Is this patient going to recover? Or are they going to need ongoing support? For the cardiogenic shock patient, do we need to start considering other interventions, percutaneous coronary interventions, other forms of mechanical support, durable mechanical support, cardiac transplantation? Those those decision points are really can be very amorphous, and having more data, particularly related to perfusion, could be quite helpful, to be sure.
So there are some incredible point of care ultrasound technologies that have come out recently, and there are people working on all kinds of technologies all over the place, us included. How fast can these changes happen? Is there value to point testing versus continuous testing? How do you see that? What should people be working on to help?
Yeah, I think that's a great question, and questions that are most certainly testable, but that I don't think we have the answer to, right? I'm a less is more kind of guy in general. And that's just the way I approach. I think that's good for a critical care cardiologist, to be honest with you, and an advanced heart failure transplant cardiologist as well. Again, never in the history of modern medicine has doing too much or more than enough for the patient been associated with better outcomes, right? Again, our job is to get them stabilized, to provide the appropriate therapies, to reach this sort of homeostatic equilibrium, and then again, get out of the way or offer them more therapies to get them out of the hospital. So that applies not just to the therapies we apply, but how we evaluate these patients. I have to get good at aggregating tons of data, right? I'm in the ICU. I'm constantly bombarded with tons of data. There are alarms going off all over the place. I've got everything on the monitor. I've got labs coming back to me. I've got vital signs coming back to me. And I have to take all that data and sort of aggregate it into a sort of a unified picture, and then create a therapeutic or management plan based on that
For each patient.
for each patient. And then be prepared for the possibility, I'd like to say limited possibility, but that's not always the case, the possibility that the decision that I make is not the right one.
Mm-hmm.
And then be prepared to pivot. So I have to think multiple steps down the road. So, any strategy of diagnosis and monitoring within a critically ill patient has to be ultimately studied and used appropriately within the context of all the other data. I personally think understanding in real time the value of perfusion markers or the potential benefit of perfusion markers would be a really important thing for someone like myself who takes care of these patients. We've started to learn over time that invasive hemodynamics from the Swan-Ganz catheter for these patients may improve outcomes, right? We think that they might. It used to be that we said, based on early data from the ESCAPE trial in heart failure populations, that there was no value to invasive hemodynamics. But a lot of us said, phooey to that study. We're gonna still use this therapy within our shock patients, and particularly our cardiogenic shock patients. And there is observational data that suggests that the employment of those monitoring tools may be associated with better outcomes. It doesn't say that Swan-Ganz catheter is what's saving the patient,
Right.
But being able to aggregate that data. So I think data is helpful. Understanding the trajectory is helpful, but understanding how to aggregate all that information together to then execute a therapeutic plan that's beneficial to the patients, that's where the challenge ensues. That's why, it's been so hard to prove that a lot of therapies within the ICU setting actually benefit the patients, because there's so many things going on. What we really need in this space are not necessarily therapeutic or monitoring studies per se individually, but really strategy or process studies, where we take tools like a perfusion monitor, like invasive hemodynamics or a Swan-Ganz catheter, and we use them together as sort of a strategy and compare one strategy to the other. And then really show that does serial monitoring of this information in the early decompensating stage, in the recovery stage, does that help improve outcomes for patients? I bet they do, but setting these trials can be really challenging.
Yeah, well, see.
Yeah, one of the other things that I think about often is that right now we're talking about the sort of acutely decompensated patient, but especially for heart failure patients, they're sort of chronically decompensated. So if they were sick before you saw them, then they probably will be sick after you see them. So I'm curious how the role or how the knowledge about perfusion, how could technology development companies better help smooth out the sort of staccato nature of the care from the patient's perspective to give you what you need before they came in, and for you to have some understanding of what happened after the intervention?
That's a great question. And that makes that, sort of that, it kind of pushes us to think really outside the box, right? I mean, I historically follow advanced heart failure patients in the clinic setting, in the ambulatory setting. I often joke around that what we don't need is critical care cardiology, although that's putting myself out of business if I say don't. But what we need is preventative critical care. If we can prevent the onset of critical illness, and we're going to be benefiting so many patients. So the idea of sort of being able to apply perfusion monitoring, something that's easily applied in the ambulatory setting, in the clinic, or even at home, to understand early that part of the trajectory, if patients are getting worse, how they're responding to the pharmacotherapies we're giving them, how they're responding to resynchronization therapies, other interventions that precede that ICU course. I think that would be really useful to know. Again, I'm just sort of just spitballing and thinking outside
I know
the box
sometimes
here,
the patients just come in new to you.
but I think that's helpful. The other patient population that I've taken care of my entire career are the mechanically supported patients, the durable LVAD patients. And I know this may be challenging, but if you can figure out a way to measure and monitor perfusion in those that may not have a pulse, that may have non-pulsatile blood flow, well, that would be a real game changer for our patient population, because it's so challenging to measure how well they're doing based on sort of just gross vital signs and other biological markers in a growing patient population supported with durable mechanical support technologies. That's another place where it'd be helpful. In the post-operative cardiac surgical population, where we have relied historically heavily on invasive hemodynamics to help usher in recovery following a major heart surgery. That's an area where I think serial perfusion monitoring can be very useful. It'd probably help us get patients out of the ICU quicker. It'd probably help us wean vasoactive therapies, which we know are potentially injurious to patients, help us to wean those quicker. I think there's a lot of potential applicability in that space. And I bet you if you talk to our electrophysiology colleagues and our interventional cardiology colleagues, I bet they'd tell you a few other areas that they'd be interested in understanding the perfusion status of the patient, and not just at a single snapshot in time, but serially over a very short period of time, and sometimes over more, as you mentioned, a more longitudinal care time.
Yeah. I had another thought recently, peppering you with a bunch of just random questions I have here.
This is where the nerd in me gets out.
It's good. That's clear what we're here for. The growth of all these amazing ultrasound technologies made us recognize that part of the transformational ability of that care is the fact you can pull out this device from your code and just do a quick check. We usually talk about perfusion monitoring in its serial nature and developing a time series of data to look at trends. Do you think there's a way that we could be useful as a spot check, or do you think we should really focus more on the time series data?
Yes.
Okay.
I think both. That's my generic area. I think there's value to a spot check and understanding in a moment in time a perfusion status of patient. And I think there's great value in understanding trajectory of perfusion. Absolutely. I think, again, I don't carry around an ultrasound probe with me, but many of the trainees these days do carry a little butterfly echo for point of care ultrasound. Certainly point of care ultrasound in the intensive care setting has become a really valuable tool. But again, it tells you gross structural and functional information about the heart. It can tell you a little bit about cardiac loading conditions. It can tell you a lot about the extracardiac organs and their status. But it can't tell you about how well oxygenated the tissue is. It can't tell you how well perfused the end organs are. And so I think, again, it's all about the use of sort of complementary data and tools to really aggregate an overall picture and then develop, as I mentioned, a strategy or a process for improving the outcome of that patient. But it is nice. I mean, the nice thing about those point of care ultrasounds is you apply it to every individual patient. Just like I would assume perfusion monitoring, you could apply it to every individual patient. So,
well, we have been pulled into this space by you and your colleagues, and so there are so many opportunities to help. We think, and with good guidance, we'll hopefully provide something of value. But conversations like this are really helpful for us to get us on the right track. So I appreciate you spending time with us.
anytime. Thanks so much.
Great. Thanks, Dr. Katz.
Thanks.